So I have 3 minutes to talk to you about the implementation challenges for hepatitis B care in the Gambia. I will run through this like a 3-minute thesis. I would not spend much time on this slide, but it basically summarizes all the viral hepatitis elimination efforts in the Gambia since the launch of the WHO elimination goals. I would just emphasize on this part that the Gambia has applied for global fund support to support viral hepatitis services, and this would include the prevention of mother-to-child transmission in the sense of antenatal screening and providing prophylaxis for pregnant women. And this support was approved by the Global Fund, and it will be part of the package for the Gambia in the next round, which starts next year. So in terms of discussing the elimination challenges, I would talk about them under the key themes of the WHO upcoming guidelines, which is prevention of mother-to-child transmission, expanding access to treatment for the general population, using diagnostics and service delivery. In terms of PMTCT, the cornerstone of hepatitis B prevention in the Gambia has always been vaccination, with the Gambia being the first African country to adopt hepatitis B vaccination and the birth dose vaccine. However, we just had completed a survey looking at the population level, what has been the trend of timely birth dose vaccine coverage in the general population, and the trend, although we've observed an upward trend since 2015, overall coverage rates have remained significantly below the WHO targets of 50% and 90% by 2020 and 2030. And we especially observed that the birth dose coverage is lower during weekends and amongst births that occur outside of health facilities. And this goes to demonstrate that the vaccine needs to be at the place where the children are born, and perhaps it's not best to keep it in the EPI program as we currently have in the Gambia in many other African countries. Antenatal testing is offered on an ad hoc basis, mostly because women have to pay out of pocket and the test kits are not always available, even though they are relatively cheaper. And at the moment, there is no access to antivirals for prophylaxis amongst pregnant women at antenatal services. We hope that this would change with the Global Fund support. In terms of expanding treatment guidelines, at the moment, there is no access to hepatitis B antivirals outside of the HIV program and research programs in the Gambia. The Ministry of Health is in discussions with the government of Egypt to provide antivirals for both hepatitis B and C, and we hope that at least this would increase access to antivirals, but at the moment, there is nothing available. There are very limited access to specialists for liver care. At the moment, it's only 2 hepatologists in the entire Gambia and a few infectious diseases doctors, and there are no decentralized services for hepatitis B care. All of the patients diagnosed would have to be referred to one of 2 centers across the country. ALT and hepatitis B DNA diagnostics are very limited outside of major hospitals, of which we only have 7 in the country. As a result of all of these, despite a very high prevalence in the Gambia, hepatitis B testing remains low. Knowledge, even amongst healthcare workers, is poor, and we don't have any testing or care services for children at the moment. In terms of diagnostics, point-of-care hepatitis B testing, there are only 2 laboratories in the country that can offer PCRs, one of which is a private research lab. We do have a wide network of gene expert machines across the country. It used to be 6 with the COVID, and additional 14 were installed, and they're spread across the breadth of the country. 17 of these are functional, but only 4 of them have been installed with the expert hepatitis B assay. We conducted a study to assess the turnaround time of using gene expert compared to qPCR on time to having viral load results and time to treatment initiation. And we saw that using this point-of-care DNA testing does significantly reduce the turnaround time for both availability of results and treatment initiation. However, there are significant operational challenges that need to be considered as we scale up implementation of these. There is a very delayed shipment of the cartridges upon order. And with a very short shelf life, it makes it difficult to do bulk orders, and there's a median of 12 weeks delay from when you place an order to when you receive the cartridges in country. The cost is also a major barrier, even though the official prices for the gene expert cartridges are relatively lower. the per test cost for the Gambia, including freight and other charges, comes to about $16.50 per test, which is not affordable to most of the general population in the Gambia. We also observe a not so insignificant amount of losses of GeneXpert cartridges with error or invalid results at a rate of about 1 to 5 tests for every 50 GeneXpert tests that we do. And the equipment maintenance also requires a bit of financing and logistics that are not always available, especially in rural health facilities. Now, the service delivery plans for the country, we recently completed with the Ministry of Health an assessment of all the major health centers and hospitals in the country to determine where is the best way to offer decentralized hepatitis B services. And it was agreed that it would be best to integrate these into the existing HIV clinics. We now have HIV treatment sites in all the major health centers and all the hospitals across the country. And all of these sites are supported by a GeneXpert machine. Hepatitis B services would be offered by HIV clinicians, nurses, and social workers, and general physicians who sit in outpatient departments will be trained to offer diagnosis and screening for hepatitis B with an opt-out strategy where everyone walking into the health facility aged above a certain threshold to be determined will be offered a hepatitis B surface antigen test. Testing treatment will be offered, again, based on the new guidelines and based on the local logistics, but will likely revolve around using point-of-care diagnostics for where it is available. Issues around how to pay for this test are being discussed right now, but a national insurance scheme is likely to be rolled out in the next year, and we are now lobbying for GeneXpert and for point-of-care hepatitis B DNA to be included as one of the services in this insurance scheme. A clear referral pathway would be developed for referring patients with advanced or suspected advanced disease to the specialist centers which are in the urban centers, and access to tenofovir or other antivirals hopefully will be available through the Egypt partnership. In terms of PMTCT, the Global Fund support we expect would scale up regular hepatitis B surface antigen testing and availability of antivirals. And there are discussions at the moment to offer continued hepatitis B treatment amongst women of childbearing age who are likely to be pregnant again within a couple of years of completing their prophylaxis. Again, questions of who would pay for this treatment in between pregnancies, as they are not strictly covered by the Global Fund support. And task shifting to provide the birth dose vaccine at the place where children are delivered. That is to give them to the midwives and to the community health nurses. And a national Ministry of Health policy is being drafted to make the shift of the access of the control of the hepatitis B birth dose vaccine from the EPI program to the program and child health programs. And I think my 3 minutes is up. I'll stop here, but happy to discuss further in the panel. Thank you.